Hello and good day. So today we're going to continue the last session for your preliminary exam topic for your critical care nursing. And with that, we will be starting with your coronary artery syndrome. I know most of you here are already familiar with this type of syndrome. Maybe some of you experienced this one or two of your loved ones already experienced this one. So the first one here is we're going to talk about your unstable angina. Now, if we say unstable angina, it is the unexpected chest pain or discomfort at rest. Now, if you're going to see this illustration here, there's already a ruptured plaque with non-occlusive thrombus. So it means that this one here, and a plaque that already developed in our body is being ruptured, and that's the time that we're going to experience chest pain. Now, with this one, the chest pain that we are experiencing here is associated even if we are doing some activities or even if we are at rest. That is why it is called as your unstable angina. Now, we also have here what we call as your progressive mechanical obstruction. As you can see here, it's almost half of the vein or the artery that is um, being accommodated by these plaques. These plaques, okay? Now here, let's go to your acute myocardial infarction or your AMI. So we have the two types. We have your ST segment elevation MI, and we also have your non-ST segment elevation. Now the first one here, this is the normal ECG. However, if a person is experiencing AMI, there's going to be an elevation in your ST as being portrayed here in this ECG reading. However, there's also your non-ST segment elevation, just like this one. So whenever you see an illustration like this for your ECG reading, you can identify what type of acute myocardial infarction it is. It's because you can identify that one here because the ST segment is elevated. However, here it's a bit depressed. Okay, now let's move on here. So if we talk about your angina pectoris, it is the Latin word for choke, and it is caused by transient reversible myocardial ischemia precipitated by an imbalance between myocardial oxygen demand and your myocardial oxygen supply. Now, if we say here transient, it means that it's not permanent. Okay, so it means it's like hopping from one place to another. Reversible myocardial ischemia, it means like it can still be treated. Okay, and there's of course an imbalance in your oxygen demand in your myocardial supply. This is because it is caused by reduced supply of oxygen because of your atherosclerotic narrowing of your coronary arteries. It means that there's already a progressive or increased amount of plaques in our artery, making the blood supply decreases and the supply all over our body also decreases. Okay, now here, what you're going to remember in your angina pectoris is that it is the most common cause of reduced supply oxygen, and also a less common cause of your unstable angina is the dynamic obstruction resulting from the intense focal spasm of your coronary artery. And then maybe it's because there's also inflammation already happening there. There will be a decrease of oxygen supply that is resulting to your unstable angina. Okay. Um, I think one of the hallmarks of your increased oxygen demand, patient will be experiencing fever, tachycardia, as well as thyroxicosis. Okay. Now moving on here, in your acute coronary syndrome, we're still talking about your um, angina pectoris. So this one is the balance between your oxygen supply and demand is not being met. So there's going to be a myocardial tissue. Um, it needs a lot of oxygen and nutrients in order for it to continue. Okay, now the same work of pumping blood must be accomplished with less available energy and oxygen. Now, what is happening further is your myocardial tissue depends on the blood supply becomes ischemic. Okay, I know you already know this term, which is the ischemic, as it functions with less oxygenated blood. Now, there's going to be anaerobic metabolism can provide only 6% of the total energy needed. Now, glucose uptake by the cells is marked increase as glycogen and adenosine triphosphates stores are being depleted. It's because there's occlusion, and if there's occlusion, the the distribution of oxygen and nutrients in our body is being affected. Okay, now it's because also of your potassium, it rapidly moves out to your myocardial cells during ischemic, and then acidotic bath develops, further compromising your cellular metabolism. And that's the time that we're going to experience such pain. Now, how about this one? In terms of the types of your angina pectoris, we have your stable angina. It says here in our illustration, it is effort angina triggered by physical or mental exhaustion. It results or resolves with rest or nitrates. Okay. Now, what is happening here? There's sometimes a paroxysmal substernal pain that is predictable. And if we are exerting a lot of physical, strength or doing some activities, as well as if we are in our emotional stress, we will be experiencing your stable angina. It says here resolves with rest, nitrates, as well as your nitroglycerin. Okay, we also have your unstable angina, which is the second one. This is the new onset or worsening angina that is unpredictable. It should be resolved by rest as well as medicine. Now, acute coronary syndrome, this may lead to your myocardial infarction. Okay, now cardiac chest pain that usually occurs while at rest and more prolonged and severe chest discomfort. It requires immediate treatment because of the um, increased risk of your acute myocardial infarction or sometimes cardiac dysrhythmias or cardiac sudden death. We also have what we term as your variant angina. This one is a form of your unstable angina. It occurs at rest, most often between midnight and 8 in the morning. This one is a result of your coronary spasm. Okay, now let's move on to the next one. So, in order for us to properly check and okay, let's continue here with your assessment. Of course, one of the pertinent thing that you're going to do as nurses in the future is taking the health history of the client who experiences or experience your angina pectoris. Now, the patient baseline before the onset of the pain, of course, anything else should be normal. Now, the onset is the time when the pain or discomfort is started. Okay, so you should be noting those important data. Now, in terms of your precipitating and palliative factors, if we say precipitating, these are the things or activities that actually led to experiencing your angina. Now, it can be your exercise after a large meal, exertion, walking on a cold or windy day, cold weather, stress or anxiety, anger or fear. So, these are the examples of factors that can actually lead to patients experiencing your angina pectoris. Now, if we say palliative, what are the remedies, the medicines, or the things that they must do in order to lessen the discomfort or the pain? They can actually stop the exercise. They need to sit down and take some rest, use sublingual nitroglycerin, or it's because here it says that pain of the MI is often not relieved by your sublingual nitroglycerin. Now let's move on here. So if the patient is still complaining of um, chest pain or angina pectoris in the emergency room or in the OPD, they will be um, they will be undergoing diagnostic tests, and one of which is your 12-lead ECG, in which you already perform and have done your return demonstration in your RLE subject. Now here, as you can see, the T wave inversions and the ST segment depressions. Okay, so this one is during the pain, and this one is your 2 minutes later, and the pain already ended. Sometimes in bigger hospitals, they're doing your exercise stress tests, wherein they're going to have or take your ECG and BP during and after the stress or the exercise stress test. Your pharmacological stress tests for adenosine, dobutamine, and dipydramol. Unable to exercise meds increases your myocardial oxygen demand while patient remains inactive. Other thing here that is being taken or being monitored, of course, is the blood chemistry. If there's an increase or decrease of your sodium, potassium, chloride, magnesium, as well as your calcium, in which they are very particular, and they're always always in connection with your myocardial activity. Your lipid profile, they're going to check if you have an elevated cholesterol, and of course if there are already plaques developing in the arteries, your CBC as well, coagulation studies, the TROP-T and the TROP-I, in which we're going to learn later on, remain elevated between 5 to 14 days, and your CRP-WBC, it means if it's elevated, there's a presence of inflammation. It means there's already infection. Okay. Now here, another thing is your cardiac imaging studies or your coronary angiography. What is happening here, as you can see, there's a catheter that is being inserted in the femoral area. Now it goes directly to your cardiac or to your heart. This is an invasive diagnostic test that actually provides a definitive diagnosis of your coronary artery disease, and the results are used to guide the decision to manage the patient medically or sometimes surgically. Okay, so what is this again? This is your coronary angiography, in which they're going to insert a catheter. Now let's move on here. And of course, it's because there's already an imbalance of your oxygen supply and demand. So our main goal here is to restore the balance. Okay, so we're going to assess the patient's vital signs, mental status frequently. I hope you already know how to do your what is that kind of assessment again, wherein you're going to check the responses of your client. Maybe later on I will remember that one. We also have here, patient is placed under a cardiac monitor for ischemia and dysrhythmia detection. Most likely they are on bed rest without bathroom privileges. It's because you'll never know when does your angina will attack. Supplemental oxygen, there's always be O2 kit and inhalation or paraphernalia beside the patient. Pulse oximeter in order for us to check the oxygen saturation of our client, and of course ABG. Okay, now let's move on to the next one, which is your management in terms of your pharmacological therapy. Number one there is your nitroglycerin. Okay, so we all know that your nitroglycerin is a vasodilator that reduces your myocardial oxygen demand by decreasing your ventricular preload via vasodilation. So it goes with your sublingual, oral spray, or intravenously. It improves your arterial and collateral flow of your ischemic areas. Okay, IV is not relieved by spray or sublingual. So you should be starting with your 10 microgram by continuous infusion and titrated by 10 microgram per minute every 3 to 5 minutes until some symptoms or blood pressure response is noted. Now let's go here. How about your morphine? So morphine is usually being used to relieve severe pain. Okay, so it is your opioid analgesic. You already know this one in your pharmacology. It actually works in our brain, and it changes how our body feel and respond to the pain. Okay, so we also have your beta blockers. Decreased myocardial contractility reduces the work of the heart, which reduces the myocardial oxygen demand. So if you're going to notice, most of the medications that the patient is being taking in terms of angina pectoris is to balance the demand and supply of the oxygen level. Okay, now let's move on here. We also have your calcium channel blocker. In your calcium channel blocker, decrease your myocardial oxygen demand as well by decreasing your afterload contractility and your heart rate. Okay, the next one, we also have your anticoagulants. In your anticoagulants, aspirin should be administered as soon as unstable angina or your NSTMI is diagnosed. The next one is we have your ACE inhibitors and your angiotensin II receptor blockers. So every medicine that ends with your pril, they are your ACE inhibitors, and every medicine that ends with your TAN, they're your angiotensin II receptor blocker. Okay, so most of this one is to relieve some symptoms and to decrease the blood pressure of our clients. Now let's move on here. Okay, another thing that being considered for patients who are having this one is your intra-aortic balloon pump. Now, what is happening here, there is an inflatable device that actually helps to boost your blood flow in your heart if our heart is actually weak, as you can see here in our illustration. So there's an insertion of balloon. Now your PTCA here, this is your percutaneous transluminal coronary angioplasty. What is happening here is this is minimal invasive procedure that actually opens the blocked coronary artery to improve the blood flow of the heart muscle. So you can see here, you'll be inserting this one, and then they're going to inflate it until such time that there will be a good passageway of blood. Okay, now here, this is a stent placement, or which there is going to be a collapse around a balloon at the tip of your catheter. So you can see here, this is guided through your artery to the blockage, and at the blockage the balloon is inflated and a spring-like stent expands and locks into your or inside your artery. Now your CABG here, this is your coronary artery bypass grafting. This is a surgical procedure used to treat your coronary heart disease, and it diverts the blood around the narrowed or clogged parts of the major arteries to improve the blood flow and, of course, the oxygen supply in our heart. Another here that we can do, so in order for us not to be at risk of this kind of disease, we have to stop smoking. And of course, to achieve or maintain optimum weight and exercise daily, we should know our normal BMI and we should attain to that always. Diet and medication: restrict coffee, low salt, low fat diet, patient education, and routine checkups. Now, here smoking, it's because it can actually build up the plaques inside our arteries. Next one is prolonged ischemia caused by MI. We're already in your MI. So your MI is your prolonged ischemia caused by an imbalance between your oxygen supply and oxygen demand causes by your myocardial infarction. Now, the prolonged ischemia causes irreversible cell damage and multiple cell death. It's because there's already insufficient blood as well as insufficient oxygen to that part of the heart. So the cells there are being damaged and the cardiac muscle are dying. Now, the presence of the coronary artery thrombosis characterizes most of your MI, as you can see here. Okay, now in terms of the pathophysiology of this one, of course, there's going to be your atherosclerosis. And this one is, what is happening here is there's going to be dysfunction endothelium resulting to your inflammatory response, which the plaques will be ruptured. And then if the plaques will be ruptured, of course, there's going to be formation of your thrombus. And if there are thrombus in the arteries, there's going to be occlusion or decrease in the blood flow, in which it will result to your myocardial infarction. Okay, so you can see here the history: heaviness, squeezing, choking, or smothering sensation, someone sitting on the chest. Ito yung sinasabi nila minsan na ang bigat ng pakiramdam or para silang dinadaganan ng elepante. Okay, that is your MI. Substernal pain can radiate to the neck, left arm, back, or jaw. Now, pain is prolonged and unrelieved by rest or sublingual nitroglycerin. In comparison to your angina, angina is actually being relieved by rest and your nitroglycerin. But in your myocardial infarction, they cannot be relieved by this palliative factors. Okay, and there will be SOB, shortness of breath, nausea, as well as vomiting. Now, mainly this is because of a family history. One or two of your family member already experienced this one. Maybe your parents, grandparents have heart disease condition, or blood pressure condition. This one is familial. Okay, physical assessment with this one is we have your cardiovascular examination. So this one is left lateral decubitus position, abnormal precordial pulsation, and lack of point of your maximal impulse at the presence of your diffuse contraction. Now, a fourth heart sound is heard in almost all patients with MI as a result of decreased left ventricular compliance. Okay. Now, other thing here, you have your cardiovascular exam. So as you can see here, we have what we call as your pericardial friction rub. Okay, this is after 48 to 72 hours. It can actually develop after your MI. What is happening here, it actually resembles the sound of leather. If you have a leather, or if you already heard a squeaky sound of the leather, it's like that. So it is often described as grating, scratching, or rasping sensation, and the sound seems very close to the ear and may seem louder than, or may even mask the other heart sounds. Okay, now the sound usually is best heard between the apex and sternum, but may be widespread. Okay, so that is your pericardial friction. Now, other thing here that you can notice with patients with MI is they have your distended jugular vein. Okay, what what is happening here, this can actually be related to the development of complications such as your heart failure or pulmonary edema. Remember, if there's pulmonary edema, there's accumulation of fluid in the lungs, and it will showcase your distended jugular vein. Breathing may be labored and rapid, and fine crackles, coarse crackles, or rhonchi may be heard when auscultating the lungs. And of course, it will not be removed to the normal routine of the clients experiencing MI. There's going to be an ECG reading. And as you can see here in the MI, T wave inversion or ST segment depression. Okay, as you can see here, then this one is depressed. In myocardial injury, ST segment elevation also have downward concave or cove shape and merge unnoticed with the T wave. And here in MI, there's going to be a tall peak T wave, symmetrical T wave inversion, as the segment elevation or development of the Q wave, and there's going to be here, so you can see this one. Laboratory exam for patient with your MI is your CK and also your CKMB. So CK is actually all over our body. It is distributed, and of course we're going to concentrate on your CKMB that is found on your myocardial muscle. So your CK is actually an enzyme found in the heart and skeletal muscles, and is usually released in the blood when the heart muscle is actually being damaged. Okay, so whenever the patient experience MI, these enzymes will actually go out. Now, in your CKMB, we have found in CKMB1 is in plasma, and CKMB2 is in your tissue. So that's wrong spelling. Okay, so in your CKMB, it more definitive of your MI. It appears in the serum in the 3 to 12 hours, and it peaks in 24 hours and returns to normal level within 48 to 72 hours. Your TROP-I here, and then your TROP-T, and your troponin is actually a contractile protein with two subforms, which is your I and your T, and a highly specific for your cardiac muscle. So troponin levels are not detected in the healthy person, and skeletal muscle injury does not affect the level. Okay, so these are being detected whenever the patient actually experiences MI or there's already a heart muscle problem. Okay, and this is the preferred biomarker for patients who are experiencing your myocardial infarction. Now let's move on here. Of course, early management for this one is to administer aspirin. Now, aspirin is it can actually diminish your platelet aggression. I hope you've encountered the term platelet aggression. This is the process by which the platelet adhere to each other at the site of your vascular injury. Example is your myocardial infarction, and then this is recognized as critical for homeostatic plug formation and also thrombosis. Now, number 2 is recording initial 12-lead ECG plays the patient in the cardiac monitor. This is to detect, of course, your dysrhythmias and ST segment changes. If it's elevated or depressed, you already know it's MI. Oxygen cannula, you already know this one, to prevent your hypoxemia, because hypoxemia often occurs in MI because of your pulmonary edema and may be intubated if respiratory distress happens. Okay, and of course your pulse oximeter to check the oxygen saturation. It should always be within normal scale from 95 to 100, and of course ABG may be drawn. Okay, moving on here. Administer sublingual nitroglycerin. This one is to promote vasodilation. Already know these things. Um, it is also for the control of your hypertension and for management of your pulmonary congestion. The next one is to provide an adequate analgesia with your morphine sulfate. However, you need to watch out for respiratory distress and hypotension with this medication. Administer B blockers may diminish myocardial oxygen demand by reducing your heart rate, systemic arterial pressure, and your myocardial contractility. In terms of your fibrinolytic therapy, or sometimes known as your thrombolytic therapy, this one is emergency treatment used to dissolve the blood clots before they become fatal. And if you or your loved ones has a heart attack, stroke, or another condition caused by a blood clot, this fibrinolytic therapy or your thrombolytic therapy can help prevent the death and reduce the long-term side effects of any kind of myocardial infarction or heart attack or even stroke. Another thing, we have your percutaneous coronary intervention, your PCI. You already know this one. Invasive procedure in which the infarction-related coronary artery is dilated with a balloon catheter. These are actually self-explanatory, and just read this intermediate care management, frequent vital signs taken and continuous cardiac monitor with ST segment monitoring, serial ECG and serial evaluation of your serum cardiac markers for infarctions are being recorded. Serum hematology and chemistry, remain on bed rest, careful attention on pain and relief. So we should always be attending to our patients whenever they are confined with this kind of therapy. Okay. Another thing here, of course, a pulse oximeter is used to monitor oxygen saturation. You already know these things. Nothing per orem until pain is free. When pain-free, patient is given clear liquids and progress to a heart-healthy diet as ordered. And of course, they need to continue that one until they will be discharged, so that there will be no other formation of thrombus or plaques in their arteries. Daily weights are recorded, and intake and output are measured to detect fluid retention. Now, stool softeners are administered so that the patient avoids a Valsalva maneuver. Remember, these are being precipitated by exertion of effort. Now, in order for them not to have angina or myocardial infarction, they should not be having difficulty in defecating. Okay? And I think the last one for our topic in your cardiac topics for your preliminary is your cardiac tamponade. Now, this one is known as both a symptom and injury can result from penetrating and blunt trauma. This is life-threatening that needs to be assessed and treated. Now, signs and symptoms with this one is decreased blood pressure, muffled heart sounds, and increased CVP manifested by distended neck veins, pulsus paradoxus, and inspiratory systole fall in arterial pressure of 10 milligram or more during your normal breathing caused by fall in your cardiac output. As you can see here in our illustration, this is your pericardium, and then there's buildup of fluid or sometimes blood in our heart. Okay. Now, in diagnosing this one, it needs to undergo echocardiogram. Treatment is airway control, oxygenation, hemodynamic support, and rapid transport to definitive care center. Okay. And of course, there's going to be your drainage of the blood from your pericardial sac or your pericardiocentesis. So you can see here, it's because there's already buildup of fluid or blood. We need to extract that one. We need to drain that one in order for our heart not to feel drowned, and it can go on with its normal function. Okay, now we also have your inotropes. These are medications for your myocardial contraction and cardiac output. Most likely you will be encountering a lot of this medicine in the intensive care unit and medical wards whenever you will be having your hospital duties. So we have your dopamine. So this one is most widely used inotropic drug. We also have your dubutamine. Okay, just read these things. When if you're going to read this one, you will already understand its relevance, its side effects, as well as the things that you're going to watch out for. So this is your dubutamine. You also have your epinephrine and also your vasopressin. Okay, and lastly, we have your norepinephrine. Okay, so that's it. So these are all the topics that you need to review for your preliminary exam to critical care nursing. So that's all. Thank you and have a great day.